Good day, dear student. Today we will have a lecture on discipline, prevention and communal dentistry. The theme of our lecture is a strategy for maintaining dental health, creation and implementation of prevention programs. Purpose of the lecture: get acquainted with principles of creation and levels of implementation of programs for the prevention of dental diseases. Methods for evaluating their effectiveness. Relevance of the lecture. In line with the WHO global targets to improve the oral health of the population by 2020. The priority of community health programs is maintaining oral health. Communal dentistry consists is health, dental health, dental pathology, epidemiology, prevalence of dental diseases, communal dentistry. Global goals: to improve dental health by 2020. WHO, Council of Chief Specialists in Dentistry, European Association for Dental Education, European Association for Public Health in Dentistry. And goals: it is safe oral health, reduce the influence of risk factors for the occurrence of dental diseases, effective use of integrated approaches for the implementation of prevention programs. Make oral health a priority in community health programs. Ensure the availability of prevention throughout a person's life. To replenish the world database of dental morbidity. And we see in this map dental caries for index KPU, big KPU in the population age 35-44 years in the countries of the world in 25. And we see in Russian it is a moderate, in Ukrainian moderate, in America, USA it is moderate, in Canada high, in Europe high. Strategy for preserving dental health. use of fluorides, reduced consumption of sugars, the use of vegetables and fruits, improving oral hygiene, breastfeeding, smoking cessation, prevention of injuries of the maxillofacial region, elimination of malnutrition, ensuring the availability of preventive care. Direction for the Preservation of Dental Health by WHO. Elimination of risk factors for the occurrence of dental diseases. Nutrition, fluoride, smoking. Next, dental health and infectious diseases, HIV, AIDS control, obesity, diabetes, cardiovascular system, oncology, osteoporosis. The third, main target groups: school children and young people, and older people. 4. System of dental care. Accessibility. Focus on prevention. Dental staff. 5. Information systems. Information about trends in dental mobility. Risk factors. Effectiveness of community programs. Patterns of health preservation. For a systematic understanding of dental health and the development of prevention programs. Model: Faith in health. People should be aware that they are susceptible to illness and to prevent it. It is necessary to follow the recommendation of specialists, despite the fact that this requires material cost. The degree of trust is influenced by age, national and cultural traditions. Model: Choice of health is built on the interaction of several factors that affected dental health. Elements of these models: social demographic features, to social interaction and to experience, social interaction to knowledge, experience and knowledge about himself, experience to patient preference, knowledge to the trust, and then to choice for health. Socio-demographic features: age, nationality, income, education, marital status, accessibility. Social interaction with dental staff, family, friends. Experience: previous dental treatment, satisfaction with its quality. Knowledge: awareness of risk factors and prevention of dental diseases. Patient preference: role in decision making, perception of doctors' recommendations. Trust: the degree of trust in the doctor, the effectiveness of preventive measures, awareness of the importance of dental health, the risk and benefits of treatment. Chronic disease help model for Professor Baer 23. Effective communication between patient and doctor. Progressive diseases such as caries, periodontitis can be prevented by changing the behavior of the patient. Levels of prevention, individual prevention. The goal is the diagnosis of risk factors and their elimination or minimization at the level of an individual, taking into account the lifestyle, somatic and dental health of the individual. Individual prevention. The level of events. It is office and home. Contingent. From persons by negotiability. Directed to a dental examination by narrow specialists. During scheduled examination in organized groups. Individual prevention. The first. Examination in stages. Second. Identification of risk factors at the stage. Third. Forecast based on the definite risk factors. 4. Measures preventive. 5. Performance, medical staff, patient and his family. Determining the individual risk level for developing dental diseases. Developing a strategy. Stage of survey. Place of residence. Antenatal development. Somatic background. The nature of the food. Bad habits. Function status. The state of the functions of the maxillofacial region. Architectonics of soft tissues of the oral cavity. Saliva parameters. Bite. Dental deposits. Dental condition. Periodontal condition. And we see how look in Russian how look dental note. At each stage, identify risk factors, diseases, predict the development of pathology, determine preventive measures, scope, performers, medical staff, patient, family. Volume of activities performed by them. For example, stage, place of residence, risk factor, deficiency of fluorine in water, prognosis, high activity of carriers, measures, systematic and local application of fluorides, performers, medical staff, doctor, prescribing fluorine preparation. And the next performance, it is the patient and family, ensuring the intake use of drugs. The next example. State of functions. Risk factor. Mouse breathing. Prognosis. Bite pathology, xerostomia, cheilitis. Activities. Consultation with an otolaryngologist, sanitation of the nasopharynx, and myogymnastics. Performers. Medical staff, consultation of the dentist and an otolaryngologist. Teaching parents and children myogymnastics. The next performance, patient and family. Conducting myogymnastics. Control, self-control. The activity of a doctor must be legally competent and economically justified. Therefore, standards for diagnosing risk are necessary. More than 30 risk factors for caries are known. Their significance, sensitivity and specificity is formed from 58 to 80%. The most significant are the intensity of index KPU and the increase in intensity. Social factors that determine the dental health of an individual. 1993. The first, it is socio-economic, cultural and environmental factors. Second, living and working conditions. Food, education, working environment, unemployment, housing. Health system, water supply, sanitation. Third, social environment. 4. Lifestyle of the individual. 5. Gender, age, physical development. The strategic role of individual prevention is to increase preventive activity with an increase in the risk of developing caries. Developing the program. Availability, the patient financially, physiologically, medical institution, technically, medicines, in the distribution network, in a medical institution, staff, time. Performer readiness. Patient, motivated, responsible. Patient and parents. Medical institution, knowledge of the functional duties of medical personnel. Doctor, nurse. Preventive actions. Drawing up a prevention plan. Health education. Parental counseling. Teaching oral hygiene. Control. Professional oral hygiene. Local application of fluoride preparations. Myogymnastics. Grinding of tubercles of temporary teeth. Separation of temporary teeth. Fissure sealing. Program implementation. The selected methods are planned in a full course. Determine the timing of control visits. Familiarize the patient with the program successful criteria. Record the plan agreed with the patient in the outpatient card. Write out a referral to a specialist with an indication of the preliminary diagnosis. Identified risk factor and the purpose for which the patient was referred. Classification of diagnosis, treatment, manipulation, and other. Program performance evaluation. After the end of the program, in the nearest future, it is about from 1 to 3 months. Remote terms, 6 months, 1, 2, and 3 years. Criteria: elimination, minimization of the pathogenic action of the risk factor, compliance of the level of dental health of the patient with the planned one. Advantage of an individual program. Maximum preventive effect. Disadvantages. In real conditions, they do not provide noticeable changes in the dental status of the population of the region. Economic reasons are costly for the state and the individual. Temporary causes are long-term. The mentality is a low level of demand among the population. Communal. The goal is to motivate the team to perform group preventive procedures with the help of sanitary educational work, to teach how to carry out preventive measures at home on their own. Group prevention. The level of activities is collective. Pregnant women in school for mothers, kindergartens, schools, industries, sanatoriums, children's and in dental clinics, health centers. Contingent. A group of patients united by several common risk factors for the development of dental diseases. Age, fluoride level in water, profession, somatic pathology. Conditional groups. Future parents, parents of newborns and children under 2 years old. School-age children from 3 to 6 years old. Children of primary from 6 to 9 years old, and secondary school age from 10 to 14 years old. High school students from 15 to 18 years old. Young people from 80 to 25 years old. Adult population from 25 to 64 years old. Elderly people over 65 years old. Activity group prevention. Organization of rational public catering. Health education. Training in hygienic care of the oral cavity. Use of the systematic fluoride supplements, salt, milk, tablets, fluoridated water at school. The use of local fluoride preparations, rinses, applications. Myogymnastics. Non-invasive sealing. Group prevention. Performance. Dentist. Initiator. Consultant. Identifies risk factors, selects preventive measures, monitors implementation, analyzes effectiveness. Gynecologists, pediatricians, nursing staff, teachers, educator, support staff, students, pupils. Sanitary educational work with parents, with children, depending on age, with teenagers, with the elderly and those caring for them. Advantages of the program. Availability, cheapness, do not require personnel with higher medical education and special equipment. Disadvantages: do not take into account the characteristics of the maxillofacial region of the individual. Individual risk factors. The effectiveness is lower in comparison with the individual program. Population prevention. Community. The goal is to correct or eliminate technical risk factors for dental diseases that are common to all residents of the region, country. Target factors: poor oral hygiene, fluorine deficiency in water and food, high intake of carbohydrates. Population prevention. Performers: dentist, epidemiological examination, holding seminars and conferences. Administration: material support, documentary support of programs, dental staff, health education, journalists, trade, public service workers. Performance. Advantages of the program: availability, does not require a doctor's time. Profitability, in comparison with individual and group programs, the larger, the cheaper. Do not depend on the preventive activity of the population, fluoridation of water and salt. Disadvantages: organizational difficulties, do not take into account the characteristics of the maxillofacial region of the individual and group risk factors. Lack of patient feedback. communal level. Social device in social control, in safety, in social guarantees and political effectiveness, and of course of support. Staff and resource needs assessment. To calculate the cost of the program, the following data are required: the number of persons among whom the program will be implemented, methods of prevention used, the cost of preventive measures, staff salaries, cost of equipment, transport and travel expenses. Other associated costs. Approval of the program, a phases introduction of the program among a limited contingent of the population with a preliminary assessment of effectiveness. Correction of the program by changing individual components in case of insufficient effectiveness or changing conditions. Wide implementation of the program. After the elimination of deficiencies among the general population of the target groups. Preliminary evaluation of efficiency. In order to correct the program after its testing. This is an analysis of the dynamics of indicator of dental status and assessment of how to the population accepted the program, the degree of its participation. Intermediate evaluation. In key age groups after the widespread introduction of the program. allows you to modify and adjust it to achieve maximum effect. Final evaluation. 5, 10 or more years after implementation. Principles of performance assessment. The same age groups are examined at the beginning and at the end of the program. From about 12 years old. When comparing results, use adequate control groups, comparison groups. The examination is carried out by specialists who have been trained and calibrated. Use the same assessment criteria for baseline and follow-up dental status. Efficiency of prevention. Caries. The proportion of persons free from caries healthy. KPU big, KPU small and KP small. Reduction in the increase in the intensity of caries. Periodont. Increase in the number of individuals with healthy periodontal tissues. Reducing the number of sextants with sinks of damage. According to criteria of the index KPU, CPI. Oral hygiene training. Plaque indexes. First evaluation of the program after 4 to 6 weeks. Efficiency of hygienic education. The number of lectures, booklets, information materials presented to the population. The number of people involved in the oral hygiene education program at different levels. The number of toothbrushes and pastes. Hygiene products sold on average to one person in the region. Improvement in dental status. Number of people involved. Degree of involvement of the population. Degree of awareness. Subjective assessment. Questioning. Dynamics of indices of the hygienic index. The state of the oral cavity. Objective assessment. Reducing the amount of sugar consumed per year per capita. Economic efficiency of the program according to the formula based on international experience. Produced cost for number of people to time divide to average KPU to number of people to time. Economic benefits of the program. The difference between the funds spent on the economic efficiency. Prevention program and the expected cost of treatment. If prevention turned out to the economical up profitable, then this indicates an insufficient justification of the program and should be reviewed as soon as possible. That's all for today. Thank you for your attention. Goodbye.